Thank you for joining Covenant Health Conversations. I'm Josh Cox, and I'm excited to bring you inside Covenant Health and the people who know it best. In this new series, I'll be sitting down with physicians, leaders, and team members from across the system to learn more about the people, technology, and services shaping our community. Together, we'll talk about work happening inside our hospitals and where the future of healthcare is headed. Whether you're a team member, patient, community member, or health podcast junkie, we're glad you're here. Welcome to Covenant Health Conversations. On today's episode, we're joined by Dr. Ayaz Rahman, Executive Medical Director of Cardiovascular Services, and Interventional Cardiologist, Dr. Briana Costello.
There's a lot more to life than just your job, right? But when our jobs are taking care of people, it is inevitably a big part of your life.
It's good to take time away from what you do perfecting your craft to also just be a human and enjoy life. Our ability to relate to the patient during their most vulnerable times, that is what will separate us from everyone else.
You get to form these bonds with people who share things with you that they don't share with anyone else. The physicians that we have here are great. They're not only smart, but they're kind, still have some ability to have some personal connection. That's hard to find. We care about how you're doing. It's not just that 15-minute snapshot in the clinic or in the hospital. Hopefully patients feel that way, and if they don't, we're here to make that change if it's not happening.
That is what ultimately Covenant Heart will be known for.
Hi, everybody. I'm Josh Cox. On this episode of Covenant Health Conversations, I'm joined by Dr. Ayaz Rahman, the Executive Medical Director of Cardiology Services at Covenant Health, and cardiologist Briana Costello. Thank you guys for being here today.
Thanks for having us.
Yeah, it's a pleasure to be here.
So to get us started, just kind of out of the gate, tell us a little bit about where you guys went to medical school, where you trained after that, and kind of how you got to Covenant Health.
You want to start, Dr. Rahman?
Ladies first.
All right. So I actually am born and raised in Ohio. So I did my undergrad and my medical school in Ohio University, then down to Wright State, which is in Dayton. From there, I went over to Rush in Chicago, Illinois, where I did my internal medicine residency. I actually loved that experience. Really great place to train, great city to be at, and then found myself in Houston, Texas at Texas Heart Institute for my cardiology and my interventional cardiology training. I actually stayed on and was staff there at Texas Heart Institute for about 4 years. And then after having 2 children, decided that my family was too far and made our way halfway back here to Knoxville. And we're so excited. We're happy to be here.
Great. Dr. Rahman?
I'm a East Tennessee native. I was born in New Jersey, but quickly after birth, my dad took his first and only job as an internist in Loudoun County, which is where I was raised, and then stayed locally for high school. And then I went to a unique 6-year medical program in Kansas City, Missouri, where I did my bachelor's and doctorate degree in 6 years. And then felt like I was a little bit socially awkward after missing out on 2 years of college. So I took a ski-batical year for a year, and then I had the opportunity to train at Emory for internal medicine, stayed there for cardiology. There was a time where I thought I'd go into academics, so I did a 4-year cardiology fellowship with an emphasis on research. And then did a year in interventional cardiology and then a structural fellowship at Emory, and then finished all that up after 9 years in Atlanta and started at Covenant in 2014.
Wow, that's quite the background. Tell me a little bit more about a ski-batical. Where was that at?
So my medical school, I wanted to take like a whole year off and just be a ski bum and, work odd jobs and ski. And I knew life would be intense once internship started. And so, but my school said, well, you got to do something academic. We can't just let you leave for a year. And so I did some cardiac CT research up in Boston at Massachusetts General Hospital. And so by day, I would do research. At night, I used to work at this building in the financial district as like their concierge person, and learned a lot about life actually in that role. And like, it's interesting the way people, see you in the role that you were in. But I really enjoyed that experience. And then on the weekends, or like more like 3 to 4 day weekends, I would go up to Vermont and Maine and ski. And so it was a fun time. I wouldn't change it. In fact, I would encourage my children to do something similar. But medicine is intense. I think a medicine residency and fellowship training, it's a little bit militaristic. And it's good to take time away from what you do in perfecting your craft to also just be a human and enjoy life, meet other people, do something that you will totally never do again. So it was a good experience for me.
You mentioned sort of the intensity with what you guys do. What keeps you guys motivated to sort of, if it's a ski weekend, time with your family, like what you guys do is intense. It's important. Like how do you focus on that and then sort of disconnect with that to then move on. End of day. Yeah, I guess. I mean, because like to your point, like I look at you guys, I'm like, whoa, these people are cardiologists. They know what's happening. But you got kids and families and you're doing your thing. Like how do you stay focused on what you do, which is super important, but then disconnect to come back motivated day after day?
That's it's a great question, actually, because I think it's probably different. An answer is different for everyone, right? Some people, that's just their life and medicine is their life. And for me, I've carved it into part of my life because I think there's a lot more to life than just your job, right? But when our jobs are taking care of people, it is inevitably a big part of your life. So what keeps me motivated for work is really the patients. It's so cheesy, and I know it's cheesy, but you get to form these bonds with people who share things with you that they don't share with anyone else, or they're going through the hardest part of their life with you, right? So you have this, they almost become a part of your family, like an extension, and you get to follow them after you hopefully make it through that hardest part of their life. They can come see you and they can grow and continue to thrive, hopefully, after that, right? But on a day-to-day basis, personally, work is work. And then I have children. I have 2 kids and a husband and 2 dogs and 2 cats and 2 fish and like a crazy life at home that I look forward to going home to. So compartmentalizing a little bit is life. Being in medicine also, you just accept that it bleeds a little bit into that normal home life. But that's a part of the job that we are really lucky to do. And, I don't think there's any other job that I would be as happy doing. So I'm very proud to say that's how I feel about my job.
How do you feel the organization supports you guys in that role, right? Because there's, from what I do, there's always, a good setup in terms of, kind of that work-life balance, that cliche, but it seems that, with where our organization is putting patients first, you have to be supported on the back end too, to sort of have that life balance too. Do you feel like Covenant supports you guys in that way?
Yeah. What do you do how do you make it through,
Yeah, I agree with you. I think like for me, there's a time when you go through training where it's grueling, right? There's like call and the work is, just by sheer amount of human hours that you put into the craft, it takes a while to get fully baked out of the oven until you're done with training. But the patients, I would say, especially in this community, they really view you not only as a physician, but you are sometimes their confidant. You are sometimes, providing pastoral services to them. You are sometimes, you are there with them in their most vulnerable moments, but you're also there to share in happiness, like when their kids get married or they become grandparents. And I think that's what, is so unique about this community. I'll give you a story. Like, my mom, when I was a fellow at Emory, she was having some knee issues and ultimately needed a knee replacement. And I said, Mom, no, don't worry about it. I've got like the world's best knee surgeon here. He's like a world-renowned guy. I've reached out to him. He's going to get you in, take care of your knee. She kind of listened to the story and she's like, no, I'm actually going to have my surgery here at Loudon. And I was like, at Loudon? And she was like, yeah. She's like, Chris Shaver's my orthopedist, and I've known him forever. And, he took care of your dad, and that's where I'm going. And I said, yeah, but Mom, like this guy's like world famous. Like, I mean, like,
yeah.
And like, I felt like I was like, I'm a fellow at Emory, and I kind of got this in, and like, yeah, and like, let me get you in, yeah. And he's going to take care of my mom, and like, and that made me realize, like, patients in this community, they are very loyal to their physicians. They're very loyal to their community. And I think it's an honor to come back and to be a part of like an organization that supports that loyalty. But I think the second thing that keeps me, I think, going is just my colleagues. Briana is one of them. I think it's really neat to have a situation where you're surrounded by people that went through the same thing that you did, right? It gives you more energy. It gives you the ability to kind of fight through those things like, hey, Brianna's got kids. I've got kids.
We got this.
And she was up last night and she's got to go to this thing for her kid at school. And like, I had to do the same thing. And, and like when you meet like people that are super smart, that trained at world renowned places, but you can have a conversation with them like, hey, like we've got this laundry issue going on in our house. Like, like we just have so much laundry and we don't have time to do it. How do you do it? And you kind of go through the process and you're like, there are other people that are like, just like me that are, I don't want to say fighting the same fight. It's just going through the same aspects of life. And it's really neat to kind of, when I started in the practice, my wife and I, we were just the two of us. We didn't have any kids. And so in my practice, when I joined, I was the youngest by like 20 years. And then there was a wave of cardiologists that came through, like Briana and stuff that, you were like, okay, like, there are people that are like my age or close to my age that are going through the same things in life that I am. And so you meet them socially, you meet their spouses and their children, you meet them at the playground, at school events. And that's what makes life, right? You have people that are really good at their craft, but they're also really good mothers, they're really good daughters and really good spouses. I mean, all the things.
Yeah. It's actually fun. Like you have to step back sometimes. Even I like have to step back and be like, wow, that call was really terrible, right? I was there until 10 or I'm up all night. But then you like take a deep breath and you're like, but I got to do this, and this for these people. And, sometimes it's not always good outcomes, but you got to be involved in this time in the life of someone. And that is something they will never forget, right? So we have like one of the most intimate jobs with patients that exist, right? And so then you get to come home and you have your family and then you're more grateful for what you have, which sounds really bad, but like you're grateful.
Good reset, right?
You have to say like, wow, I walked into this house that has electricity and water and my husband is here and my kids are healthy. Like we have it's a great job. It's a great community. It's a great set of colleagues, which I mean, truly when you can find a colleague like Rahman who is walking this path that is this part of life and you say, wow, you get it. Like, and you've got a wife that's busy as you know what too. And we've still figured it out. You figure it out.
So let's lean in a little bit more to you talk about colleagues and kind of who you work with and what makes it so great. How many cardiologists, how many heart doctors do we have at Covenant Health?
Good question.
And are there different specialties and subspecialties within heart care?
Yeah, I think so. Combined cardiologists, cardiac surgeons. We have. We'll have to fact check these numbers.
Yeah, that's okay.
I think over 30. And in addition, we have APPs that support the service line, both from a surgical and cardiology standpoint. So the family is pretty large. When you go through training, it's neat to collaborate with colleagues over tough cases and things. And I would say that our environment is very diverse, not just in terms of skill set, but age. And the things that different people bring to the table are unique. And so when you have a tough case, it's nice to be able to call up a colleague, say, hey, take a look at this. And it feels like fellowship again or residency, where you have a more formal academic feel. And I think we have something similar locally here at Covenant.
Rahman or Sarah Negrado, I know that they have done a lot of these cases. Or in my practice, I know that Josh Todd has experience with this disease or this coronary problem, right? And being able to bounce ideas off your partners is important. I think it's actually it's best for patients when someone can say, hey, you know what? I'm going to get a second opinion or a third opinion or a fourth opinion, or sit 3 people down and say, what do you guys think? Because the most challenging cases, it's not a pride badge to do it on your own and think you have the best answer. it's better to collaborate. And that's what Covenant offers, collaboration, because we have enough brains to get together and come up with maybe a better solution than the one you thought was, right? And so I think that's a great part of Covenant. We have a great wealth of people who have different experiences, training, background. It's a really great place to be.
Great. Thank you, guys. Let's shift a little bit towards kind of cardiology and then heart health. When, people hear the word cardiology, they might think heart attack. They might think kind of worst case scenario. What are some of the other reasons that, somebody might end up in your exam room to see you guys?
That's a good one for you.
I think oftentimes, you're right. We see when even the media has sensationalized cardiology to these heart attack moments or open heart surgery. But we see a lot more, and it is something that is going to be a point of emphasis in the service line on preventative health as it pertains to cardiac disease. Oftentimes, we go through life, even as physicians, maybe I should get my cholesterol checked, but what age should I do that? My parents have a aggressive family history of heart disease or high blood pressure or stroke. And so I think for us as a group of cardiologists and cardiac providers in the community, it's going to be really important to educate the community on prevention, because like anything else in life, whether it's cancer, prevention is your best policy. That being said, oftentimes we do meet patients in extraordinarily vulnerable times where you are the first person that's meeting them while they're having a heart attack. And it's and you're telling them you're going to do all these things to them in a very fast way. And it's really scary. If you've ever been on the other side, it's vulnerable in many ways, mainly because of how you're feeling and you don't feel well. But, you walk in and you're like, you ask yourself, well, how did Dr. Costello look? Does she seem like, she was excited about this? Like she could get this done? Did she seem confident? Was her tone good? Did the body language make sense? What about her team in the room? Did they seem like, well put together, like an indie carpet, or did they seem like a little bit discombobulated? So I think it's really important for us as cardiologists to almost be symphony maestros. We have to make sure that everything and everyone is doing their job at a really high level in order to take care of the most important prize, which is the patient. And part of that is, how you deliver that message. So I think prevention is going to be key moving forward. I think we have to educate ourselves and the medical community on what that means, but also patients. But, also making sure in those vulnerable moments that we really deliver care in a way that patients remember, wow, not only was Dr. Costello an amazing interventionalist technically, but she made me and my family feel so good.
Yeah, I think that's it's super important. Like your first impression, they say the first impression is like the last impression. I think that you have to remember that patient and their family, they're all staring at you thinking, oh, this is the worst time of my family member's life. Is it going to be okay? Are they going to make it? And so that impression, it's not fake. Like when Rahman sees someone, he's genuinely concerned about that heart attack, right? And he's getting all of his ducks in a row in his brain. What am I going to do? Is this going to be, what approach am I going to use? What have they had done in the past? It's a big conversation in our own head. And we have to remember that we have to make sure that we're there to comfort the patient while we're technically going through our checklist as well. But that being said, that's like the note, sensational. Everyone thinks about heart attack, but some of the best medicine or cardiology that we do is in the clinic when we meet a patient who just comes in because mom or dad had a heart attack when they were 40 and they're terrified, right? That fear for them is almost just as much as that guy who's had 2 heart attacks. So prevention, talking about how to risk stratify patients, what treatments or what testing they need, that is huge. And with social media, because everyone does it now. I mean, there's so many, these medical influencers, which some have knowledge that they're imparting on people, but some, they need to come fact check it with us and say hey, let's talk about what you read, or let's talk about what we need to do, or what testing is important for you. A lot more in the clinic now. I see that, well, I saw online that I might need this, or I saw I might need this, or I saw that statins do this. So I think a lot of what our job is also is guiding people on the right path and letting them choose what journey you want to take for your health. But let me give you what we know from a scientific standpoint.
You talk about prevention and preventative medicine. What are some of the biggest measures that somebody can take to make sure that their heart is in a healthy state. I'm sure consulting with their primary care, physician is first thing, but the standard things of exercise, eating well, those things. But what would you say that would be, hey, if you're looking and you're concerned about maybe a family history with your heart, what are some things that you can control right out of the gate?
There's like a checklist I go through, and I don't know if you have something kind of similar.
I try to, for me, I try to understand where the patient is at when they see me. So one of the questions I always ask in clinic is, what did you have for dinner last night? And I ask it really quickly so that they can't, like if you ask someone, like if someone asks me the question, like, what do you feel like you eat healthy? Well,
yes,
yeah, Dr. Costello, I eat salads 5 days a week. Yeah. And, but at the end of the day, like, what they did last night or, what was the most strenuous thing that you did last week? And they're kind of like, so you kind of put a framework around where the patient is at. And I think that's really important. Like, it's really easy for us to sit and say, like, hey, listen, you got to exercise 5 days a week, 30 to 45 minutes. Here's what you got to eat. And you kind of sound like, you're lecturing them. And I think delivering that message is you got to find where the patient is at and kind of bring them to where they are. Obviously from a prevention standpoint, depending on, what the checklist is and what you find, there are, various tests that we can do. There are things that are even coming down the pipeline, like submolecules of like cholesterol. And does that give you a higher risk if you have a positive family history or something like that? And I think there will be things that come down in the future beyond that with AI-based platforms and things, looking at CT scans and like really fancy things. But I think at a granular level, I think diet and exercise and, where the patient is at in the continuum of where they see you is going to be really important as we counsel them.
Yeah. And that's funny that you asked about dinner, because I'll say, what did you have for breakfast before you came here? And if they say they didn't eat, I said, okay, then what about dinner last night? And that gives you a sneak peek into what is their daily life, right? And some people will say, well, I don't eat that much. But then, for dinner I had a steak and I had a potato and then we had some mac and cheese. It was homemade. And you're kind of like, okay, tell me more. Because it's a lifestyle. If you grew up eating this way, that's normal, right? So if that's your lifestyle, that's normal and that's healthy because you grew up that way. And so then, you have to break that down, which can take some time. And building that rapport is hard, especially when you have a patient. I'm from Ohio, or they think I'm from Houston, and they're from East Tennessee, and they have a farm, and they have their own cows, and they're like, wait, you're telling me red meat's not good every day? And so you're kind of unwinding decades of what they think is good, and it's not all bad. You just talk about modifications, right? And there are some people that I'm more strict, and there's some people that I'm, you're here for prevention. You're 45, your lipids look great, you exercise 5 days a week. If you want to have steak once a week, that's something that you got to factor in your brain, right? So each patient is very individualized. There are other people that have had an MI or a heart attack and they're overweight and they're not active. And those are the people that you really kind of I get a little more technical and a little more strict, just to kind of, if you're super strict, if they fall in the middle of that, at least they've made some progress. So I think everyone's individual. Cholesterol, blood pressure. Blood pressure is the number one risk for heart attacks, right? If you aren't a smoker, it's the number one risk factor that we can help modify with a patient. I love to talk about it. It's under talked about. Everyone thinks the primary care is doing it. The primary care is 100 other things they're doing. So if I can spend 2 minutes on just talking about what the blood pressure should be and how often you can check it, I feel like it's a win, because most people do not check their blood pressure. They think, I feel fine, must be fine. But it's not true. So I think blood pressure is low-hanging fruit, exercise, and lifestyle modifications are like my biggest prevention.
Same. I think there's certain things that, there's sometimes tough discussions to have, tobacco use is one of them. And I always start that conversation with listen, I have lots of friends and family that smoke. So I'm like you, we're in the same situation, but, I think you have to somehow get the patient to trust you and to trust, this process, because it's a lifestyle, like Briana said. It's something that is just not a check-in every 6 months. And it's kind of when you go to the dentist, okay, I'm going to floss the week before. And it's not one of those things. You kind of have to it's got to be sustainable. So, telling a vegetarian that you should abide by a keto diet, well, you're not really relating to them. That's not what they live by, right? So And in the same vein, like telling a farmer, like, yes, you raise and, herd cattle and that's part of your diet. Well, you have to meet them halfway to create that relationship so that they'll trust you long term.
It's like meeting the patient where they're at, meet them where they're at, and then figure out a way to improve what their risk is, right? It's not always perfect.
Yeah, I imagine some of those conversations can be tough. And, speaking from personal experience, if you come into a physician's office and they're not building that rapport, they're not trying to meet you where you're at. It's sort of like, hey, you're not doing this. This is what you need to be doing. It can be off-putting. It just depends on, I think the personality of the patient too. Like for me, I would love if I had a cardiac issue, for you to be like, hey, you're not doing this. You should do this, this, and this. But that's me,
you.
Right?
Yep.
And everybody's certainly different. Heart disease in men and women. What differences are there? Is it just based again kind of on your makeup? Like my cardiac makeup might be different than somebody who's older, maybe doesn't exercise as much, doesn't eat as healthy. Is it as simple as that between men and women, or is it just really, kind of what your individual case is?
You want to field part of that one?
Yeah. I think I'll start off with, I think the first and most important thing to know is that women's cardiac disease is underdiagnosed, and for that reason is undertreated. It's been well published, it's well known. And so, we are taught in training about, various manifestations of how women present with cardiac disease versus how men present. But I think as cardiac providers to the community, you have to go into it knowing that that women are in a minority, and for that reason, you have to go above and beyond to diagnose and to treat. And I'll let Briana kind of touch upon some of the nuances that exist between men and women. But I think you have to go into it with that knowledge, whether you're a male cardiologist or a female cardiologist.
Both, for sure. There's like a little implicit bias, the buzzwords I used to hear not long ago, like implicit bias that if you have two humans, one male and one female, coming in with the same symptoms, inherently, because you're trained and it's ingrained in your brain from day one of medical school that, men die from heart attacks. And they're trying, the American Heart Association in particular, they're trying really hard to push this, get this narrative out. But you just see a man who's having chest pain and a woman who's having chest pain, and then the inherent thought is, well, is the woman really having a heart attack? When it's a man who comes in with chest pain, that's the first thing on the list, right? And the truth is, yes, there are disparities or differences, I should say, in what symptoms people come in with. There's published data on this too. More often, chest pain is by far and away the most common for both, right? But women will often present with more palpitations or neck pain than men. So you can study this up and down, left and right. But if you lower your kind of threshold for saying, okay, this could be a heart attack or this could be a cardiac problem, then we can get closer to treating patients more equally. So women, yes, they present sometimes differently, but the truth is, I think that in the clinician or the diagnostician's role, we have to have more clinical acumen and more kind of thoughts that this could be this. It's not the patient's job to make up a story about their chest pain. They're telling you what they're feeling. So you have to have an index of suspicion and be able to treat them the same. Historically, of course, it's men who've had the heart attack, but we know that men and women have the same rate of heart attacks. And women used to, until a few years ago, die more from cardiac disease than men before this American Heart Association kind of push for Go Red for Women really started. And now the rates have finally started to get closer together. So we've made some strides, but the fact that disparity still exists, it just is telling, right? Now, I will say for women, and this is I say it because I think patients will remember it. Women are just like men after menopause, which we're protected for a little while with our own inherent estrogen. But when that estrogen is gone after menopause, your risk factors go up, period. Your cholesterol often goes up. The blood pressure goes up. You lose that kind of protective estrogen effect. And especially if you're a woman who's had preeclampsia, eclampsia, or gestational diabetes, you already have a higher risk than your female counterpart that did not have that when they had children. So you have an extra risk factor. So all this is to say there are disparities, there are differences, there are X, Y, and Z, but we're getting better. We just have to be actively thinking about this when we treat patients. And as a female in cardiology, I think it is part of one of the things that I love to do is treat the women who have felt like perhaps they've been ignored or looked over. But I think our male counterparts are getting there. I think Rahman can speak for that. Like 10 years ago, 20 years ago, this whole Go Red for Women and, challenges for women with heart disease didn't even exist. People didn't even acknowledge it until they came out with the data, right? So I think it's getting a lot better. I think we just have to keep it in the forefront of our brain when we see a patient.
That's interesting. I'm not a woman, obviously, but I'd not heard that, kind of those pre-existing conditions once you kind of hit that, menopause state. Do you feel that, from an education standpoint, the information outside of, the American Heart Association it's equal for men and women? Is it something that is becoming better through the AHA, or it's still kind of lacking?
It's lacking.
Yeah.
There's, one of my best friends that I trained with, she's an advanced heart failure specialist, but her major focus of research is healthcare disparities as it pertains to heart failure. And so we know that that women who have cardiac disease sometimes have unique cardiac disease. There are certain diseases like where women are more predisposed to stress-induced weakening of the heart muscle, or these interesting tears that they can sometimes get in their heart arteries. And so, recognition of those things and not treating it the same way like you treat any garden variety heart failure or a blockage is really important, because if you don't recognize it, you can actually hurt the patient. And so I think, we are much better off now than we were 10 years ago, but we have a lot of room to grow in terms of recognition and treatment strategies as it pertains to women. And I do think that there are positive things that are happening. There's some things that are happening at Covenant. We have phenomenal leaders that are women in our subspecialty. Dr. Costello is one. Dr. Sarah Negrado is another. We also have wonderful female leadership administratively at our hospitals and at our cardiac service line. And I think those things are important. You need to see, just like any minority plight, you have to see like people that look like you, that are your same gender, that went through and did the work to try to treat you in a different way because you are different. And so I think we have a lot of positive things at Covenant that recognizes that and are moving towards hopefully bridging that gap.
Yeah, it's an ongoing process.
Yeah, I imagine. It's like everything else, right? It kind of changes. You guys have talked about, kind of the trend changes in diagnoses over time. How have you seen, that diagnosis and treatment advance? What those advances look like in the field, but also, at Covenant Health?
I mean, you can box this into a few things, right? I mean, structural in itself, which Rahman leads, structural heart disease is a rapidly evolving field of cardiology. And Covenant is very much kind of been in it for how many years now? You guys have been doing this?
Yeah, we started our program in 2012. So it's odd to say it out loud that we're in our 14th year. And what used to be considered like, by some as experimental or, oh, this is too new to try is now a much more mature technology and therapies that we have. But I think that exists in the, in like Briana said, in different buckets. I think structural heart and valve disease is one. I think even in the coronary space, in the past, it was a little bit like, oh, you have heart disease, you need bypass surgery. Yeah. We lived in that environment, and I certainly trained in that environment. And now you have a lot of trials that have looked at, are minimally invasive strategies like with stents and things that you can do through a wrist. Is there equipoise between that and open heart surgery? And oftentimes there is. But we've made many advances in just routine heart attack care. Recognition of when patients are in something called shock, when their heart is failing. And I think, and part of that is, to continue to participate in research. I think that's going to be part of what we do at Covenant moving forward. We already have, and I think that's going to be important to deliver to the community that while we do have innovative technologies, we're always looking for the next thing to help you even more.
We talked this morning in a different setting in kind of terms of growth and, what the overall heart program looks like. Kind of what's the vision, for 2 years from now, 4, 6 years, for the program, recruitment. Are we looking at different specialties? Are we looking at different technology in terms of AI? You mentioned that a little bit earlier. Just kind of, high level, as the medical director, kind of what's the vision for heart care at Covenant Health?
Yeah, it's a big question. I think the first thing to, go into it with is to use our footprint as our strength. Covenant has a large footprint in East Tennessee. We have a multitude of hospitals and clinics and providers across this portion of the state, extending from the Cumberland Plateau all the way to East Tennessee. So I think the first thing is to use that as our strength and to kind of go into it knowing that whether a patient shows up in your hospital at Morristown or at Fort Sanders Regional or at Cumberland Medical Center, that the same level of cardiac care will be provided as if you went to any of the Covenant hospitals. So that's really important. I think it's also important to use all of the existing physician, resources that we have. We have amazing physicians across the health system within cardiology. One of the things that we have done are to create subspecialty councils within the cardiac service line. So the interventional council, of which Dr. Costello is a part of, and we have representation from Methodist Medical Center in Park West on that council. There will be a structural heart and valve council, a cardiac surgery council. And then there are things that, we want to do well. Prevention is one of them. I think, it's always nice to think about, okay, what's the next technology that we can get, or can we do something robotically? And I think those things are important. And for sure, we will be making strategic recruitment in those areas. But it is also really important to shore up your base, make sure you do prevention and diagnostics really well. So we hope to differentiate ourselves in cardiac imaging, whether that's through stress testing or CT scans, MRIs, things like that. And then there are some things that we really need to focus on. I think heart failure is one of them. We all take care of heart failure. Despite Dr. Costello doing an interventional fellowship and other folks doing electrophysiology fellowships, like all of us take care of heart failure. It's something that we see, but we need to have a system-wide approach in terms of how we take care of these patients along the continuum. Sometimes there are people that are just at risk for developing the disease, and sometimes they are patients that we see in the hospital that have, pump and support devices inside their heart because their heart is actively failing. And so I think we have to come up with ways and processes to take care of the patient no matter where we meet them on that continuum. So I think, 5 to 7 years from now, hopefully, I think we will use that strength analogy where we will say, we used all of our resources and we're providing high level cardiac care. And that may lead to, if you have a coronary issue and you had something during pregnancy, Dr. Costello is the person to see, and we have a subset with an area of focus and expertise in that area. Similar to other, things like heart failure, electrophysiology, atrial fibrillation, that type of thing.
Yeah. So a lot of it comes down to, your specialty, your subspecialty. We have that. To your point, what do we do well? Let's do that well, and then build on that, whether that's technology, AI, from even all the way down to a charting perspective, right? And kind of what are the tools that help you guys,
see patients more and do less of the background stuff that no one sees.
Yeah. I think AI will be, I went to this talk at our kids' school about AI, and there's the people that say, oh my God, AI is horrible, it's bad. And then they're like, oh my God, AI is the best thing. It's revolutionized my life. And I think of AI like a traffic light. There are times where it's red, and you probably shouldn't use AI for healthcare, whether you're a patient or a physician. Then there's times where it's green. You're like, Maybe it's an overlay of a CT scan and it picks up something that your naked eye couldn't pick up, and it leads to a diagnosis. And I think that's a good thing. And then there's probably yellow where it's like, maybe it's okay, maybe not.
But
Like,
fact check,
let's do our homework on this one and not just jump right in. So I do think there will be, and I think being thoughtful about how you use AI will be important.
I have this conversation with my husband all the time because he's pretty like anti-AI in life. He thinks it's going to, anyway, I won't go down that
Take
path.
over, right?
Yeah. I mean, it will take over some things, but I think my perspective is it's here. It's only going to continue to get bigger, and we either adapt and use it or it does take over, right? Because someone's going to figure out, if we don't figure out how to use it, how they can use it for us. So I think it's
a great way to put it.
Not really like you can't stop it. This train is already on its tracks. So we got to figure out a way to use it thoughtfully, use it HIPAA compliantly, and use it to benefit our patients.
You guys have shared a lot of great information about yourselves personally, about Covenant Health Heart. What's one thing each of you would want our listeners to take away from the session today?
I think for me, and I think Dr. Costello has kind of touched upon this as well, I think what I would want listeners to walk away with is that our cardiac enterprise and service line, we want to be, it should be a given that when patients walk into Dr. Costello's clinic or into Park West when I'm on call while they're having an active heart attack, or to one of our outreach clinics, that they're going to receive the most excellent clinical care. That's a given. I think what will differentiate us is the way in which patients see that we collaborate with each other as physicians and administrators, and with our teams, whether that's in the cath lab, in the ICU with our nursing staff. But above and beyond everything else, it will be our ability to relate to the patient during their most vulnerable times and how we made them feel and how we made their patients feel. I think that is what ultimately Covenant Heart will be known for, and that is what will separate us from everyone else.
And I will just dovetail on that. Again, we get to be a part of these patients' lives. It's not just a one-stop shop. Generally, a patient sees us and they end up seeing us for a long time, right? For the duration, perhaps, of their life. And knowing that we, Covenant cares, not just me, one person, Covenant cares, our staff cares. And then when you grow that, not only the clinic staff, the hospital staff, when you come in and need us to care for you in the hospital cares. And then when we get you a follow-up, we care enough to make sure that that's in place. And we call to check on you and your heart failure. That's a big one. We care about how you're doing. It's not just that 15-minute snapshot in the clinic or in the hospital. And knowing that Covenant, and I'm not to sound like it's inflating my ego, but Covenant has done a great job of recruiting amazing talent. I mean, the physicians that we have here are great. They're not only smart, but they're kind. And so they've been trained very well and also still have some ability to have some personal connection. That's hard to find. I mean, even when we're shopping for doctors, right? I'm like, well, I want someone who I can talk to, right? And so I think that Covenant not only has the wealth of knowledge in their physicians, but they have chosen physicians that they can represent Covenant well. So I think that hopefully patients feel that way. And if they don't, Covenant, I know, wants it to be that way, and we do. So we're here to make that change if it's not happening in whatever area.
Awesome. Well, thank you guys for sharing with us today. We look forward to having you guys back to talk a little bit about some different topics and dive a little bit deeper into some specialties. But I'm super stoked for you guys to kind of be a part of what we're doing on a regular basis with Covenant Health Conversations.
Yeah, can't wait. Thanks for having us.
Thanks for having us.